Welcome to this clinical masterclass explainer. Today, we're stepping right into the supervision room, pulling back the curtain on the unconscious roots hiding beneath our patients' anxiety disorders. If you're a practitioner looking to sharpen your clinical edge, or honestly just someone fascinated by the deeper workings of the human mind, you are exactly where you need to be. We're going to push way past the surface-level presentation of anxiety. We're going to learn how to truly decode what the mind is actually trying to tell us.
Julius Caesar once said, "As a rule, what is out of sight disturbs men's minds more seriously than what they see." And, that perfectly captures our task as clinicians. Our job is to look beyond those conscious, visible symptoms and find what's out of sight. Patients walk into our clinics every single day with terrifying panic, paralyzing phobias, or just this pervasive dread that seems to come entirely out of nowhere. But it's never truly out of nowhere, is it? The disturbance is just out of sight. It's our job to bring it into the light.
So, here's our syllabus for today's clinical rounds. We'll be looking at anxiety as a signal, the developmental hierarchy, formulating panic disorder, deconstructing social phobias, and finally, treating generalized anxiety.
Let's jump right into Section 1, anxiety as a signal. We really need to reconceptualize the symptom here.
All right, let's dive into this foundational concept. Initially, Freud actually thought intense panic was just a physiological buildup, like an actual neurosis. But by 1926, he completely flipped the script with the structural model. He realized that anxiety is actually a signal. Think of it as an adaptive mechanism, right? It's mobilized by the ego to warn us that forbidden thoughts, aggressive wishes, or maybe sexual impulses from the id are threatening to break right into conscious awareness. The ego essentially flashes this anxiety signal to trigger defense mechanisms, keeping that unacceptable conflict safely repressed.
This perfectly illustrates why we've got to be so careful in our practice. Look, neurobiology absolutely plays a massive role. For instance, we know nearly 70% of people have a shorter version of a specific serotonin transporter gene, which is linked to greater amygdala reactivity and a heightened fear response. But we literally cannot afford to fall into biological reductionism. If you just say, well, it's your amygdala acting up, and medicate the symptom away, you miss the psychological meaning entirely. The brain provides the hardware for the alarm, sure, but the patient's unique life history, that's what trips the wire.
Moving on to Section 2. Let's look at the developmental hierarchy, which is an incredibly practical diagnostic tool.
Honestly, as a senior therapist, this is one of the most powerful tools I can possibly hand you. When a patient sits across from you just radiating anxiety, you've got to ask yourself, at what developmental level is this fear operating? Notice how this hierarchy moves from the top down. It starts with mature superego anxiety, so moral guilt about not living up to some internal standard. Then it steps down through castration anxiety, fear of losing someone's love, and separation anxiety. Down at the very bottom, we hit the most primitive fears: persecutory anxiety, where a person fears annihilation from outside forces, and disintegration anxiety, which is just the absolute terror of the self completely fragmenting. Figuring out exactly where your patient lands on this map, that pinpoints the specific unconscious threat that's triggering them.
This brings us to Section 3, formulating panic disorder. We'll be looking at the fascinating case of Mr. M.
So, meet Mr. M. He's a 27-year-old office worker who came to the clinic complaining of severe panic attacks. But here's the catch. They only happened specifically when he tried to leave town. Now, for some context, he just bought a new house, and his wife was pregnant with their very first child. He actually told his psychiatrist he felt more like he was 7 years old than 27. And when we asked about these out-of-town trips, well, he explained he was leaving to go hunting with his father.
Notice the profound gap here between the surface symptom and the underlying dynamic. Upon further clinical probing, Mr. M admitted something huge. He had actually accidentally shot his father in 2 previous hunting accidents. No joke. The surface symptom, this panic when leaving town, completely masked a much deeper conflict. All these new adult responsibilities, becoming a father, buying a home, it triggered deeply repressed eatable rivalry and long-standing aggressive wishes toward his father. Whenever he even planned a hunting trip, the threatened emergence of those destructive impulses created massive signal anxiety. His neural substrate then transformed that signal into a full-blown panic attack, basically to physically stop him from going and committing the imagined crime. Incredible, right?
And formulating this dynamic isn't just some fun intellectual exercise, it profoundly works. Randomized controlled trials show us that when we use panic-focused psychodynamic psychotherapy to address these central conflicts around separation, anger, and autonomy, we see a massive 73% response rate. Compare that to just 39% for standard applied relaxation training.
when we help our patients increase their mentalization capacity so they can actually see their panic as representing an unconscious fear rather than a real immediate catastrophe, the clinical outcomes are just absolutely staggering.
All right, let's pivot to Section 4, Deconstructing Social Phobias. Here, we'll examine the case of Mr. N.
Our second patient, Mr. N, is a 25-year-old junior executive who developed a truly severe social phobia. He was uniquely, intensely terrified of simply introducing his own name when meeting new people at work. He would get so incredibly short of breath he couldn't even finish a basic sentence. Now, to the untrained eye, this just looks like standard generalized performance anxiety, but we need to look much closer. During a brief dynamic therapy session, his therapist asked him to just reflect on his name. Mr. N pointed out that he actually shared his father's name, and his father had abandoned the family when Mr. N was only 4 years old, leaving him to prematurely become the quote-unquote man of the house. Mr. N felt like he was just a little kid pretending to be an adult, and if people found out, they'd be furious with him. He arrived at this profound realization. To say my name is to say I'm trying to be my father. Introducing himself symbolized this profound, crushing guilt of prematurely taking his absent father's place.
Observe how perfectly this builds into the exact mechanism of a phobia. Mr. N was managing his internal anxiety through 3 distinct defenses. First up, displacement. The fear of taking his father's role was shifted onto a totally insignificant derivative, just saying his own name. Second, projection. His internal superego guilt was shifted outward. He imagined the entire social environment would disapprove of him as a fraud. And third, avoidance. He simply refused to speak in public. He essentially created an external, completely avoidable phobia just to manage an internal, unavoidable conflict.
Let's move to our final clinical round today. Section 5, Treating Generalized Anxiety, focusing on the case of Miss O. Ms. O was a 23-year-old graduate student. She presented with this chronic, escalating nighttime worry all about aging and death. She vehemently refused medication. She really wanted to understand the origins of her fears. During a session, while talking about these anxieties, she started to tear up. The therapist did what any of us would do, performed a standard supportive gesture, and offered her a box of tissues. Curiously, Ms. O flatly refused the tissue. When the therapist gently asked why, she revealed that she viewed taking a tissue as an absolutely unacceptable sign of weakness and neediness. So here is the crucial takeaway. Her superficial worry about death was actually a massive distraction. As they explored further, it became crystal clear that she had constructed this impenetrable, pseudo-independent facade. She absolutely dreaded vulnerability because to her, it literally felt like death. What she truly feared was her own suppressed, explosive anger toward her father. Her unconscious fantasy was that if she ever let her anger out, it would be so violent it would destroy him and she'd be left entirely abandoned and alone. Her generalized anxiety disorder was really just a frantic, pervasive defense against that specific, terrifying internal reality. And you know what? Once her therapist helped her deconstruct those unconscious factors, her nighttime panic completely vanished. And, as clinical trials clearly show, this isn't just an isolated anecdote. Short-term psychodynamic therapy achieves large, really stable improvements in GAD symptoms that are completely comparable to standard cognitive behavioral therapy. How? By building lasting ideational mastery. The patient learns to bind that disturbing affect to its true underlying idea rather than just letting it float freely around as generalized panic.
Keep in mind, when you're back in your own practice, pure GAD presentations are incredibly rare. Honestly, nearly 90% of GAD patients have a lifetime history of at least one other anxiety disorder. The presentation is almost always complex. It's muddy. This is exactly why a simple biological checklist is never going to be enough. And it's why this kind of careful, highly individualized clinical formulation, truly listening to the unique narrative of the person sitting across from you, is absolutely vital to successful treatment.
As we wrap up today's clinical rounds, I really want you to reflect on what we've covered. We've seen firsthand how panic, phobias, and generalized dread are definitely not random misfires of the brain. They're urgent, desperate messages from the unconscious mind. So as you head back out there to meet your next patient, I want to leave you with this final supervisory prompt to guide your practice. When your patient sits down in distress, are you just silencing their symptom, or are you truly listening to the signal?